Hello, and welcome to episode 2 of our 4-part series called Nothing to Fear, Meaningful Conversations About Life and Death. This series is in celebration of Hospice of Northwest Ohio's 40th anniversary. My name is Sara, and I've been a nurse for 12 years, most of which have been at the bedside between the intensive care unit and with Hospice of Northwest Ohio for the last 5 years. It's a privilege to be your host for this special series. We focused on a few members of our interdisciplinary team in our first episode and talked about their roles, and the physicians are certainly a vital team member. Our second episode features two of our wonderful physicians, Dr. John McGreevey and Dr. Annette Collier. This is such a great opportunity to pick your brains, and as a nurse, I very much appreciate both of you taking time out of your day to be here. So first, I would like to introduce Dr. Annette Collier.
Hi. So I've been a physician for about 30 years and have been with Hospice of Northwest Ohio about 12 years. The last 8 years of that, I've been focusing on palliative care. Prior to hospice work, I worked as a primary care physician and did some hospital work.
And second, I'm also pleased to introduce Dr. John McGreevey.
Hi, my name's John McGreevey. I've been in the Toledo area since 1975 and in practice for just shy of 40 years. About 25 of those years was spent at the medical college doing geriatric medicine, and I've been doing hospice care since 2005.
Such great careers. Thank you, guys. So I think we would be remiss if we didn't at least talk about the difference between palliative care and hospice, because this is something that gets brought up at community events often. And there are a lot of people out there who use the terms sort of interchangeably. So the way that I love to explain it, kind of the quick and dirty version, is I love to say hospice is palliative care, but palliative care is not hospice. So I would like to ask Dr. Collier to put palliative care sort of in a nutshell, and then Dr. McGreevey to do the same for hospice.
Yes, Sarah, I have used that comparison before also. So palliative care is a medical specialty. We've been a medical specialty, really our own little specialty, since about 2008. And our focus is on relieving the stress and the symptoms of serious illness. And the one big thing that sets us apart from hospice is that really all you have to do to qualify for palliative care is have a serious illness. And any age, any stage of that serious illness, patients and families can benefit from palliative care. So our focus is walking alongside that patient and family with their other clinicians while they are still seeking curative, life-prolonging therapies. And our focus is improving quality of life and enhancing their life during the treatments for their disease.
Thank you. I love that you said, any stage, any age as well, just a serious diagnosis. So Dr. McGreevey, could you do the same, sort of put hospice in a nutshell?
Sure. There are two differences. The first one is when you say hospice, you're actually defining a regulated program under Medicare and many insurance companies that people have to actually go through an evaluation and an admission and a certification process to be on. So there's a certain, for lack of a better word, bureaucracy to being on hospice care or not on hospice care. As far as the field goes, as Annette said, or as opposed to what Annette said, I guess, is that for a person to be eligible for hospice care, they need to be felt to be terminally ill, and in the judgment of two physicians, that their likely life expectancy is 6 months or less. What is usually happening at that time is that a person has a disease that is getting worse despite all efforts to control it or make it better, or the person's quality of life is just not being able to be maintained, and they are getting sicker, in and out of the hospital a lot, in and out of the emergency room a lot, rapidly losing function, all of those kinds of things. And so we get to a point where the usual treatments for the illness begin to become really burdensome or ineffective. And when that happens, when any of those things happen, that's when we start talking about hospice care.
Absolutely. Great. Thank you. So I would like to remind the audience at this point that we are taking questions live. So if you have any questions for Dr. Collier or Dr. McGreevey, please type them in the chat box. My first question for both of you is, though, what is the hardest question that you guys get from patients? And we'll start with Dr. McGreevey this time.
Well, this is a big thing to jump into, but reflecting on this, I think the hardest question we get is, frankly, when somebody asks us if we can end their life, which we do not do and we cannot do. It's not what hospice is about. It's illegal, for one thing, but it's just not what we do. But when you're asked that question, it really is an invitation to a pretty deep conversation. You just don't want to brush it off or anything like that. You need to get into what is going on with this person and what has happened to this person that they now feel that their best option is to have their life ended. So again, it's not a question that can be simply answered, but the usual answer is tell me more and let's see where we can work on it. And we can get into more of that as the discussion goes. But that's the toughest question because there are people that ask us that right from the get-go.
I think that's a hard question for even the most seasoned of healthcare professionals, whether you're a nurse or a physician. It gets brought up to all types of disciplines. And yeah, that's a tough one to answer. How about you, Dr. Collier?
Yeah, I think one of probably the most challenging question that we get, and we get it in palliative care, and I'm sure we get it, Dr. McGreevey gets it in hospice care also, is how long do I have? How long do you expect me to live? And it's difficult, not for the reason most people might think it's difficult, thinking, oh, it's really awkward or uncomfortable talking about death. It's not really that, because I think, being in this field, we're comfortable talking about death. What makes it difficult for me is when somebody asks that question, first of all, I want to be truthful. I want to give them the information if they want it and the way that they want it. But I also know that, that question may have some nuances, and really want to probe into that question before I give information, so that I'm giving them, if they want, a time frame, and then we can talk in general. Nobody has an expiration date, so I'm not going to be able to ever predict somebody's exact prognosis, but I think it's a patient's right to know if they're asking. And the other thing that makes it difficult is, even after I'm sure that they want that kind of specific information, that, like I said, we don't have exact, it's not an expiration date, that sometimes the patients and families really hold on to that time frame, and if it's shorter or longer. So it's definitely something I feel we need to be truthful about, but I want to make sure I'm giving them the right information.
Sure, that's a tough question in both fields. And as a hospice nurse, I feel like I always tried to say, number one, we don't have a crystal ball. I think people have a large actually more control than they realize over that moment. But I can talk in terms of, hours to days versus days to weeks versus weeks to months, in those more vague terms. So yeah, both of those are tough questions from patients and family members for sure. My next question for you guys is, what is the best part of your job? And we'll start with Dr. Collier.
Far and away, the best part of my job is being able to spend a lot of time with patients and families. Having done primary care before and then hospital-based care, the schedule is tight, and you have to see a lot of patients in a day. In palliative care, we still have our list of patients that we have to get through, but it's by nature of the specialty that we're expected and we're encouraged to spend a good amount of time with patients and their family. So that is, especially compared to my other job, so to speak, that is something that I really feel is a great thing about being a palliative care physician.
Yeah, I agree with you. And I think that's one of the great things about palliative care. And when I say palliative care, of course, I'm talking about hospice as well. But that time is built in for those appointments, time to talk, because these decisions and these goals of care conversations and these types of issues take time to work through. And you're right, primary care physicians have more strict timelines than maybe you guys do. How about you, Dr. McGreevey? What's the best part of your job?
It's pretty similar. I think the best part is having the ability to sit down with people, hear their stories. Hospice care is very geared toward the goals of the patient and the family at that time and what they're trying to accomplish. And so a fair bit of time is spent getting to know them and what's important to them. I like to ask the question, if you could do anything you wanted today, because sometimes people can't, what would you do? And you'd be surprised. Sometimes people have a bucket list or something big like that. I've had people tell me, I'd like nothing more than to be able to get on my riding mower and mow the lawn today. Sometimes it's a very ordinary thing. But in sitting down and getting to know people, and I've had the opportunity working with hospice to do home visits, and I just think it's a whole other level of getting to know people. The other thing, if you're paying attention, is that in a world where we're very divided and that we're all going to die, it is the one thing that connects us all. And sometimes in working with people going through that, you can get a sense of community that I don't know if you can feel in a lot of other places.
That was very, very eloquently put. And I do also love that piece of it, of getting to know people on a very, very deep level. I mean, this is a very vulnerable time in their life, and you don't get that in a lot of other career fields. And you really do get to know their family and kind of their intricacies. So we do have a good question from David. Can you talk about when hospice can be available to patients and families? Many people do not call hospice in to help until the patient is very near death. Great question, and we'll go to Dr. McGreevey for this one.
So in general, and it is an individual decision, but in general, you look for certain signs that things are getting worse despite attempts to evaluate and treat a condition. Examples: a person keeps ending up in the emergency room, or ending up being hospitalized despite attempts to stabilize what's going on to make things better. A person is no longer able to tolerate the medications. They're having more problems with side effects than they are with beneficial effects. A person is unable to maintain nutrition, losing weight despite attempts to do otherwise, to to maintain nutrition and maintain weight. They're losing function despite attempts to stabilize things. They're weaker today than they were 2 weeks ago. They no longer have the energy to do much of anything. So you see all of these different things, some of which all of us would recognize as changes in how we live our lives, some of which are more medical, like progression of a tumor despite treatment, lack of available treatment, or inability to tolerate treatment. When you see those combinations of things, suggest things aren't going well, and we don't seem to be able to change the fact that things aren't going well, that's a good time to consider hospice care. You don't have to wait until a person is bedbound. I mean, we still have people on hospice that have the energy to get out and be around some and get around, and sometimes can do more when their pain is controlled and things like that.
Absolutely. Dr. Collier, how about you? Could you talk a little bit about the palliative care side, when palliative care would be available to patients?
Okay. So, as I said in the beginning, to qualify for palliative care, really, you have to have a serious illness, and not much. You don't have to have, a limited lifespan prognosis, but so some examples of serious illnesses, cancer. Really, even early stage cancer comes with a burden, comes with symptoms of the disease, comes with symptoms or side effects of medications. It also comes with the stress and the adjustment that now you have cancer, and that changes a person's life. So really, palliative care is appropriate for cancer at the time of diagnosis. Other disease processes, heart failure, lung disease, and many of those conditions, by the time they're advanced, it has impacted somebody's quality of life. Either they're not able to do what they would like to do, they have symptoms, pain, shortness of breath, they may need some psychosocial support, but yet, their prognosis may be many years. So, so really, if you see that your life, your quality of life is affected by the disease or the treatment, I would say it's time to at least get an opinion and see if palliative care can help address those stresses.
Right. Great question, David. I think that question goes along with one of the big myths out there, which is that hospice care specifically is only for the last few days. And really, the average length of stay is a little over 2 months. And we've had people on for years before they pass. It looks like we have another question from Patty. Is it your goal to meet with each hospice patient and their primary caregiver in your role as a physician? Plus, if the patient is not able to communicate, would you make it a point to meet the primary point person, or is that the staff responsibility?
It's a mixture. Everyone who is assigned, or everyone who comes on hospice is assigned to a nurse case manager. Some people who come on hospice and are still followed by their own physicians and can be followed by their own physicians. Some patients are in long-term care facilities where there are physicians and nurse practitioners rounding. So we're not always needed for that. The nurse case manager, among his or her other duties, will be working with the patient and family and looking at what is needed. And then if needed, we go out there. And it isn't just a physician. We have a team of physicians and nurse practitioners that do that work. The other thing is that there will be times when we will go out because, as I mentioned, hospice is a program under regulatory requirements from Medicare, and sometimes we need to go out for the purpose of documenting that the person still does appear to be terminally ill. or still is appropriately qualified for hospice care. So we do not necessarily go out and see everybody on a routine basis. There are a lot of different ways it can work. What we do is have a team meeting every week with the nurses and all the other members of the team, counselors, chaplains, whoever else, and go over what's going on with the person and what their needs are.
Yeah, I think the nurse case manager in home care, especially, is certainly like the first point person, kind of the eyes and ears. And there are physician visits that happen in that home care setting, but it's kind of by request and it's not really on demand. And then it also has to do with those recertifications. So in answer to that question, though, it kind of depends on the patient's environment. And of course, if they're in our inpatient unit, they might see the physician face-to-face a little bit more often. How about you, Dr. Collier? Could you maybe speak to, we have another question here. Oh, okay, let's go to this question. How do you determine when a patient is ready and or eligible to be moved to a hospice facility versus home care? Is it based on availability or a patient's condition? So this would be for Dr. McGreevey as well.
Okay, to get hospice inpatient care, that is a specifically defined level of care by Medicare, much as if you've dealt with rehab or people with post-hospital care, much as skilled care is, where you get certified to get it. So the inpatient units, by and large, hospice inpatient care, are for people that are in an acute state. What that means is that they have active symptoms that are needing to be treated that are beyond the ability to treat in their living situation, or are very unstable and changing and so forth. It is not meant to take the place of a long-term care facility or long-term placement, with few exceptions. So it has to do predominantly with patient condition, how sick they are, how stable they are. Sometimes there are beds in a hospice that are designated more as standard care or home care level beds, that if a person wants to stay there, can stay there, and there is usually a fee for that. And when it's skilled care, Medicare or whoever is paying for everything, they're paying for the inpatient care, they're paying room and board and all that. I hope that wasn't too confusing, but just let me throw in one more thing. Hospice also can provide for periodic 5-day respite care stays, and that is another reason sometimes people might go into the unit. Say the primary caregiver of the patient on hospice themselves gets sick or has to have a procedure done or is going out of town, the hospice patient could be moved to the inpatient unit for 5 days. But for the most part, the inpatient units are not designed for the longer stay or the longer term care.
Yeah, I like to say that's kind of like a hospital for hospice patients. So it's certainly not a hospice setting, but it's, if we've been trying to control symptoms in their home environment, making med changes, it can't happen as quickly as it can in the inpatient unit when you're talking about med changes. Looks like David said, thank you for the answers and thank you for helping my mom comfortably pass. You made it a far better experience. So glad that we could help. And Patty said, thank you for answering my question. You're welcome, Patty. My next question for you guys, what advice would you give patients or families who are thinking about palliative care or hospice as an option? We'll start with Dr. Collier.
I guess the simplest and direct answer is if you're thinking about it, it's probably time to try it. And So if anything that we've said, so far this hour resonates with you, or for you or your family member, if there is some stress of a serious illness, I'd encourage you to call the Sincera office. We have it's staffed by RNs that are very experienced in hospice and palliative care that can answer most of your questions. And then many times, if it's sounding right, the office will schedule for a nurse practitioner and or social worker to come out and meet with you. It might take, a visit or two to identify exactly how palliative care can help. But there's, other than those visits, there's no commitment to stay on the program. And like compared to a hospice, there's not any strict qualifications or criteria. So I guess if anybody is thinking about it, if it resonates, get more information and have palliative care come out and see on an individual basis what they can do for you or your loved one.
Absolutely. I mean, if it's something that's on your mind that you think you could benefit from, the answer is you probably definitely will. So Dr. Collier, what are some of the symptoms that palliative care can help manage or does help manage for patients who are diagnosed with any serious illness?
By far, the most common symptom that we're dealing with is pain. And for one reason is pain is such a pervasive symptom for, we kind of think of pain as some patients with cancer have pain, but there are other chronic conditions that are associated with pain that many times when the disease process is being focused on, those symptoms are not fully addressed. So one of the other probably reasons that pain is a primary symptom that we address is that managing pain and sometimes involves the use of opiate medications, and that clinicians that practice palliative care and hospice have special expertise to address pain and to prescribe opiates if they're indicated in a safe manner, in a safe environment. The other symptoms could be shortness of breath, constipation, nausea, the stress of an illness, so the anxiety and depression. Many times when that is a primary symptom, we call in the team's other members, social worker and chaplain. And probably after pain, I would say the anxiety and just the emotional existential stress of an illness would come in number 2 as the most common symptom that we address.
Excellent. Yeah, if people had tuned into our first episode, we talked about the concept of total pain, Dame Cicely Saunders, and how it's not just physical pain, but it's that spiritual pain or that emotional pain, the psychological pain that you talked about as well. So Dr. McGreevey, do you have any advice for patients or families who are thinking about using hospice as an option?
I think first they probably should talk to their own physician, but because that's the person that knows the most about what's going on with them. And I would also say that a lot of times, if there are palliative care physicians or nurse practitioners available in the hospital, if that's where that's going on, or they're followed by a palliative care team like Dr. Collier does, they can ask those questions there, and those people are very well versed with how hospice works and can talk to them about the pros and cons of it. But if you're really trying to figure it out, you can also call the admissions office, and so a nurse there would talk to you about what's going on and maybe talk to a physician or look things over and decide whether or not this might be a good idea. And then it is possible to have a hospice admission nurse, possibly with a social worker or other kind of counselor if that's needed, come out to the house. These admission nurses, that's predominantly what they do. They do hospice admissions. And so they're pretty good at knowing when somebody's eligible for hospice or not. And that doesn't obligate. I mean, sometimes they go out and we never see the person again. Sometimes they go out, the person comes on. Sometimes they go out and the person comes on 2 or 3 months later because it's not where they were quite yet. So when you're really at that point of trying to decide, and again, finally, I would just go back to what I said earlier is when you would want to be thinking about it would be when things aren't going well, reasonable things have been tried to try to help the person be better, help the person get better. They're just not getting better, and either treatments aren't working anymore, treatments aren't available anymore, or maybe treatments are proving to be more of a burden than a benefit, like Dr. Collier said. These are times when you might want to make that call.
We definitely recognize that it's a hard call to make. The people who answer the phone are nurses, and we're there from the beginning to sort of walk you through the process and always answer questions. I do want to remind the audience out there again, we're answering questions live. So if you have a question for Dr. Collier or Dr. McGreevey, please type it in the chat box. My next question, Dr. Collier, do you have any advice for any clinicians out there who may be considering a career in this field or a path in this field?
The field is growing. Like I think I mentioned in the beginning, it's only been a specialty since about 2008. So I would say if you're the type of person that likes to get to know your patients well, again, Dr. McGreevey and I both said in palliative care and in hospice care, we get to really dive more deeply into a patient's disease process and into their family unit, into their personhood. And if that resonates with you, I think palliative care and hospice is a great field to go into. It also make future physicians or clinicians reassure them that you use everything that you've learned before in your career or in medical school. Because we see such a range of disease processes, that we really have to use our clinical skills. We have to use our physical exam skills, maybe even more than sometimes in the hospital, because our patients aren't running off for tests all the time. So I think those two things really keep me in the field: is the time with the patients and the fact that it's broad, lots of different disease states that we deal with. And the other big thing is I can't think of how my other practices consistently being able to feel like I had an impact and really make a difference, even if it maybe only got to visit with a patient a few times.
Yeah, that's beautiful too, when you really feel like you are making a difference. And I agree with you about assessment skills. Going from the ICU to hospice home care, I didn't really recognize how reliant I was on the machines in the ICU that were monitoring everything for me. So assessment skills definitely are important there. How about you, Dr. McGreevey? Any advice for any clinicians out there who may be considering a path in hospice and/or palliative care?
And just to clarify too, hospice and palliative care from the physician, nurse practitioner perspective, it's one field, although you might choose to work this place or that place. I would talk to them about the things we've been talking to today, about what it's like and what we do. And I would also urge them, where possible, to get some experience, some exposure to it to see what it's like. Because it's really, historically, it's very different from what students and residents in training and physicians in practice would encounter every day. Now, physicians in practice certainly would take care of people at the end of life, but it's a very different field. Much of it takes place out of the hospital. But I try to have a conversation much like we've been having here today. And then if they have the opportunity to experience that, round with somebody, to go spend a couple days with somebody, I'd strongly urge that. And we do some of that. Dr. Collier has had students and residents rounding with her. And we have had people students round in the inpatient units with us. So the best way to find out if you're drawn to it is to really experience it, probably.
Sure, and it's a lot more of a positive environment than people realize as well. I think you hit the nail on the head when you said that even physicians don't know the environment that well. We do have a partnership with UTMC, and I have taken, I call them, with much respect, baby doctors out, very young residents, out with me on home care visits. And I feel like 9 times out of 10, at the end of the day, they said, "This is not what I expected." I think they expected to see in hospice home care, people actively dying throughout the day. And there were people who were still going to the grocery store. And so they really had their eyes opened about what it was that we did. And we do inpatient tours for them. I believe they're with us for a week or 2 now with Dr. Paul and a group. So yeah, if anyone out there, nurses, physicians, social workers, what have you, if this is a field that you would be interested in, please talk to any one of us who works for Hospice of Northwest Ohio or Sincera Palliative Care, because I think you'll find that a lot of us love what we do, and we have a lot of long stay employees here.
Yeah. On a personal note, it was actually Dr. McGreevey 12 years ago when I was thinking of that field that I shadowed him, that I asked to spend a couple of days with him, and we spent some time in the inpatient hospice unit and some home visits. So, that experience clearly convinced me to come over and do this type of work.
Sure, I did not know that. Yeah, thanks for sharing that. So I asked this question in our first episode when I had the social worker and a couple other members of our interdisciplinary team, chaplain and a hospice aide. And the reason that I asked this question is because when I joined Hospice of Northwest Ohio, I think this was one of the questions that I was most concerned about when a patient asked me. I was like, I really don't know how to answer this, and it kind of scared me. So what do you say when someone tells you that they're scared of death or dying? And we'll start with Dr. Collier.
Thanks, Sarah. That is a very difficult question and very meaningful position to be in with your patient. I try to remind myself, if a patient says that, just to listen a little bit more and explore exactly what they're scared about. Statements like "tell me more," and have them, so that we can explore more specifically. Sometimes just being empathetic. They're saying that they're scared doesn't mean that they're expecting us to take away that fear or solve it, but giving them some time, giving an empathetic response that you hear them, and yeah, this is a scary time for many people. But most of all, just exploring it and learning more.
Yeah, I love that phrase, "tell me more." It always gives people a little bit of an opportunity to dig a tad deeper into that fear. How about you, Dr. McGreevey? What do you say when someone tells you, or if someone tells you that they're scared?
Yeah, and again, much like what we were talking about with the person that talks about ending their life, it's an invitation to a more involved conversation. And I think going in, there are a couple of things to keep in mind. We do everything we can, and the families and everybody does everything they can to make this a positive experience and make this as good an experience as it can be. Um, that said, this is a person who's looking at the end of their life. And especially if it wasn't something that they were expecting at this stage of life, or that, I mean, it's going to be scary. I think there are a few things that we should, first of all, avoid. I think we should not minimize it by saying, oh, don't say that, or you're going to be fine, or don't talk like that, or anything like that. You want the person to be able to say it. And sometimes being able to say that they're scared is what they predominantly need at that time. They're not asking you to fix it. Second thing is, as a physician, not to pretend that you can fix that completely, because we are wired to fix things, and we're not going to fix that, but we're going to assure them we're going to be there, we're going to listen to them, and we will help them with whatever we can help them with. And maybe there are very specific things they are scared of. Maybe they're scared of being in pain and not being able to relieve it. Maybe they're, find out what is there a specific thing that they are afraid of. But we have to be really careful not to trivialize it. And in trying to be positive about things, we have to realize, this is a sad time. This is a rough time. You can't just fix it. You don't want to say, I know what you feel, because unless you're dying, you don't know what they feel. In fact, maybe the thing to say is, I can't imagine what that feels like. So it's going to be as individual as there are patients, but those are some of the approaches that might help get you down the right path.
I love the don't trivialize it approach too. Kind of sit with that fear, be that safe space for the empathetic listening, like Dr. Collier said. And I always did try to clarify, are we talking about the physical act of dying? Are we talking about physical pain or fear? Or are we talking about what happens after that moment? Because that could be a couple of different types of fear, if you will. So one of the really big myths out there that I feel like I ran across almost on a weekly basis was fear of narcotics. Morphine kills people, or hospice uses morphine to kill people, which is what we've already talked about. 100% not true. That's not our philosophy at all. So if someone expresses some concern that choosing, let's say, palliative care or choosing to use narcotics would hasten their death, what would you say to them, Dr. Collier?
Once again, I would probably start asking them why they feel that way. Many people come with that belief because they've had a personal experience. Either a family member or a friend has entered hospice care and then died a couple days later. We that practice hospice and palliative care realize that patients come to hospice, unfortunately, sometimes very, very late in their disease process. And in educating that's not our purpose, that we use the opiates only for symptom relief. If somebody is actually on the program, and sometimes it's demonstrating to a family member the dosing and the response, and explaining how the doses are changed, and maybe having the family members see how we approach symptoms. But education up front and trying to see where they're coming from is really the first step that I would take.
Yeah, I love the education up front is so important. We try to talk about what's in the stat packs, the emergency packs for hospice for sure. And if we had to use these meds, let's talk about them well ahead of time. But there are so many people out there who are afraid of the word morphine or narcotic or opioid because there's a lot of misconceptions about addiction and such. So it's definitely out there. Dr. McGreevey, what would you say if you heard that someone was worried about choosing hospice or choosing to take narcotics even because either of those choices or the combination of those choices would hasten their death?
I think there's a background here. I mean, if first of all, I do think the messages over the years have tended to swing one way or the other about treating pain in public. And we're in a place right now where we've swung the pendulum away from a time where a lot of these meds were probably being prescribed too freely for everyday things. And we've gotten into some major problems with that. And we've gone to the other extreme of being really, really afraid to use them even where they would be helpful. And that's a difficult place to be. But what I try to do to reassure people is to say, number one, we start with very low doses. And I try to put it into number terms like, people that have been on pain medicines, for example, are on Percocet, that may have been on Percocet. So I might say, if they're familiar with that, the starting dose of morphine we're going to use is like if you took one of those Percocet pills, cut it in 6 pieces, and took one of the pieces. That's the kind of dose we start with when somebody's not been on. So the first thing is we start with very low doses, unless somebody's already on a substantial dose. We go up gradually. If it appears that somebody's not tolerating the medication, we'll back off on it, we will change it, and so forth. But for certain kinds of symptoms, and in hospice, the major ones are severe shortness of breath that can't be reversed any other way, or severe pain, the opioids are the safest and best drugs to use. And so I try to explain how we're going to do it, how we're going to monitor them. There is an extra complication if they have a history of substance abuse. And I don't, we would work with that and work with how we were going to manage that. That's probably a little beyond the scope of what we can get into here today, but we do look at that because we're still concerned about it. But I try to talk about the safety of the medicine, how we dose it carefully, how we advance it carefully. And we're always open to cutting back if it seems that it's hitting too hard. The problem is too that a lot of times the people that are the most afraid of hospice are the ones that will wait until the person is hours away from death and very, very sick. And then, and only then, they come on hospice. And then, of course, they die after a few hours, and then the feeling of what happened. So it can become a self-fulfilling prophecy. It's not always simple. Just sit down, we talk with people, proceed as carefully as possible. But these are safe drugs. In many ways, frankly, they're safer than some of the medicines we use over the counter, because if you have heart disease or bad high blood pressure or bleeding problems, these things like ibuprofen and Aleve may be more dangerous to you than morphine. That's why they always say, call your doctor if this or that. So it's just an ongoing conversation.
Absolutely. I mean, I totally understand the fear behind some of these medications, but I always try to put it in perspective with patients that it's not really any different than Tylenol or a beta blocker. Or even if you wanted to go as so far as to say like using alcohol. I mean, I know you're not using that to treat a symptom, but Too much alcohol, too much Tylenol, too much water even could do a lot of damage to people. So when these drugs are used in a safe manner, that they can be so effective for pain and also shortness of breath. Actually, Dr. McGreevey, could I have you touch on how narcotics work for shortness of breath quickly?
Sure.
Yeah.
They work in a few ways, and I don't know that we understand all the ways, but if you've ever been short of breath, it's terribly anxiety provoking. Your body is telling you you're in trouble here and you better do something about it. You're anxious, you're distressed, you feel bad. So, unfortunately, sometimes people have shortness of breath from either severe heart failure or a tumor or something like that, and it's no longer possible to fix the cause. They're too sick. So what the morphine does in some respects is that, number one, it will get rid of that air hunger, panicky, anxious sense. It will dampen that down, because now it's like having an alarm go off, but there's nothing you can do about what caused the alarm. So you breathe more easily. The second thing is, when you take a breath, the air has to travel down to about here before it actually even starts putting oxygen into the body. The first part of your breath isn't doing anything for you unless you can take a deep enough breath to get the air down into your lungs. Well, if you're panicked and short of breath and breathing shallowly, you take morphine, you relax a little bit, you breathe a little more slowly, you breathe a little more easily, you breathe a little more deeply, you may actually see some improvement in your oxygen level. This is something that was not at all understood 30 and 40 years ago. The idea 30 and 40 years ago was that if you gave somebody short of breath morphine, they were going to stop breathing and die. There's a big middle ground where it's useful.
Absolutely. I have seen it take away some severe shortness of breath in some COPD and lung cancer patients. I think we have one more question. Do each of you remember, of course, keeping HIPAA in mind, a specific patient or patient story that has really impacted you? I'll give you a couple seconds to think about that, and I'll tell a quick story while you're thinking. One of the patients that I had actually involves a really good story about going to the inpatient unit. My patient, I'm going to call him Mike. Mike had lymphoma and he was very, very itchy. And we tried every Sarna cream and, every topical thing we could think of. And we decided we could try a medication that is an antipsychotic, but an off-label use is to stop itching. That's called Thorazine. But Mike was at home alone a lot, and some side effects of Thorazine could be fairly scary, especially if you're alone. So I said, Mike, why don't you come to our inpatient unit? We'll start the medication. We'll monitor you for a couple of days, and then you can come back home. And at first, he was totally against it. He wanted nothing to do with going into hospice. I think it was the fear of the word, the fear of, death or dying. But eventually, he came around to it because the itching was keeping him awake. So he came to the inpatient unit. He was there for about 4 days. The Thorazine worked beautifully. He had no side effects. He went home and he lived another 3 months itch-free. The scars and the scabs healed up. His skin looked much better, and he was comfortable. And he always used to ask me to come over on visits Friday at like 4 p.m. because he would say, well, if you're off at 5, then you and I can have a beer. And he was very sarcastic. We just got along really well. So after he died, I went and bought his favorite beer of Bud Light in a 40, and my husband and I cheersed and split it. So I will always remember Mike, though, and his family. So who would like to go first? Dr. Collier or Dr. McGreevey, did you think of one?
Okay. Yeah. So I can't decide between these two, so I'll just tell them briefly. One early on was a young gentleman with esophageal cancer, and he had a heroin addiction. And he sticks out in my mind because we were able to help him safely manage his pain, without using heroin. We gave him, prescription medications to manage his pain. He got through radiation, chemo, and surgery, and hopefully is a long-term survivor. So we, in the face of opiate use disorder and being young, and that's an example of somebody early in the disease process. The second one that I just want to mention briefly was a gentleman who had very end-stage lung disease, and we helped to manage his symptoms. But even more importantly, I think we helped manage his symptoms, gave him support, and helped with some logistics to allow him to make a last wish, and that's a car trip almost across the country. And he ended up passing after he got to his destination after a couple of weeks. But that gave us a lot of our team just a lot of satisfaction that we helped him in those last days and weeks live out a dream.
That's beautiful. I love that. I think working in this field, you see so much human in humans, right? We see so much emotion and vulnerability, but beautiful things can happen. Dr. McGreevey, how about you? You got a patient story?
I'm having trouble thinking of one that I wouldn't be revealing something. Let me just say that I think there have been so many times where I've seen people that had limited energy, and it's just so much work to stay alive every day, and watched how courageously they just did what they needed to do. The one that I think is pretty safe to bring up because it's pretty short and sweet, and that is that there was a woman I was seeing in the inpatient unit, an older woman, a very friendly, nice person, had severe heart and lung disease, which was why she was there. Trouble catching her breath, trouble eating, trouble doing everything. And I don't even remember what brought this up, but I said something to her commiserating with what she was going through, and she just looked up and she said, "Oh, honey, there's people got it lots worse than I do." And I looked at this woman who could barely move and barely breathe, and that she would have that kind of an outlook about life, that she would say that. It's kind of humbling. The lessons are there all the time if you keep your eyes open.
Oh, 100%. I learned so much from patients. I had one older lady who had a fairly new diagnosis of lung cancer, and I figured walking in there would be a sad visit, a hard visit, because it was a new diagnosis and she was going on hospice. And I walked into her apartment and she said, "This pile is for my church. This pile is for Goodwill. Here's all my paperwork. I planned my funeral. I wrote my obituary. I know what people are going to eat." I mean, she had it all ready. She had totally took me by surprise. Everybody deals with it differently, of course, because it's their first time dealing with it. But well, we are at the end of our hour here. I want to say thank you to everyone who joined us and asked questions. And I want to say especially thank you to Dr. Collier and Dr. McGreevey for taking time out of your busy days to let us pick your brains a little bit. And thank you for all of your work in this field. Yeah, and if you guys have anything else you want to add before we sign off?
I would thank you.
Yes.
Thanks for having us.
Sure, yeah. All right, it was our pleasure. Yep, and a big congratulations to everyone at Hospice of Northwest Ohio for a 40-year anniversary that we'll be celebrating all year. So thanks again for joining us, and we will see you for episode 3.
Thanks, Sarah.
Yep, bye everyone.